May I begin?
For successful phacoemulsification, it's important to have a perfectly circular centered capsular axis, followed by hydrodissection, and then followed by the hydrodelineation and the creation of the golden ring. Followed by in-the-bag phacoemulsification and a bimanual IA for a well-centered IOL in the bag. The original coaxial IA can be straight or 45-degree angle, followed by a bimanual IA invention. Following femto-CCC, there is a change in technique for IA compared to manual CCC. In manual CCC, one can easily notice the free-floating fibrils of the cortex beyond the margin of the CCC, which are aspirated with the solid straight coaxial IA, or one can use a 45-degree coaxial IA with a sleeve, or even use a bimanual IA to hold on to the free-floating cortical fibrils to aspirate them. With the invent of the femto-CCC, there is a change in technique for IA. With the aspirating port, one has to reach below the CCC margin, grasp the edge of the cortex, take care that the anterior capsule margin is not held, and aspirate the cortex to complete and perform the IA. Notice the edge of the CCC. In flax, the rhexis size or the height of the resection can be adjusted from 600 microns to 700 microns or 800 microns, or even 1 millimeter above the CCC. We normally keep it at 600 microns, so it's 400 microns above and 200 microns below the anterior capsule. Post-flax, let us see the anterior segment OCT, where we see a free-floating CCC and a free-floating disc of cortex of 200 microns. In this case of a femto-CCC, notice a disc of 200 microns of free-floating cortical matter, which is now being actually elevated and separated with the help of the viscoelastic. So there are no free-floating fibrils below the CCC, which are seen in manual CCC. So the technique changed for IA, which is essential but subtle. Post-flax, to perform bimanual IA in a well-dilated pupil, one can easily hold the cortical matter just below the margin of the anterior capsule and aspirate the cortex. Let's look at a case of flax in a very hard cataract. During phacoemulsification, the pupil constricts below the margin of the CCC. So now the problem begins. Here we are using the irrigating cannula to hold the constricted iris away, but due to poor grip, it keeps slipping and makes it difficult to do cortical aspiration. Look at the struggle, and the iris keeps slipping. One can use a solid coaxial IA and use a Y in the other hand to retract the iris, hold the cortical matter and aspirate it, but it is difficult to access all the corners of the bag in such a technique. So we invented the irrigating Y. To the irrigating handle, we attached an attachment like a Y, and this attachment actually helps to hold the iris away. With the aspirating port, we can go beneath the margin of the CCC, hold the edge of the cortex and aspirate it. The design of the irrigating Y is in such a fashion that the PC is kept away because of the flow. The procedure continues. Again, the iris is held with the Y portion of the irrigating handle and the cortex is easily aspirated. With change of hands, the procedure is repeated, iris is gently retracted, the anterior capsule margin is visualized and the cortex is aspirated. The technique is very simple. Use the standard MVR to create two ports. Use the irrigating Y in a horizontal position and enter the anterior chamber. Then orient the Y vertically and go ahead with the aspirating port to hold the cortical fibers and continue to do a bimanual IA. Here is an example of using the irrigating Y. Another case where the femtorexis is performed, let's look at the use of the irrigating Y. The Y attachment gently retracts the iris and one can go beneath the CCC to hold the edge of the cortex and aspirate it. The beauty of this design is to be able to access the entire capsular bag all around. While going across, retract the iris, visualize the cortical matter and then aspirate it safely. One can access 180 degrees all around. With the change of hands, the irrigating Y can cover the other 180 degrees of the eye. So the entire 360 degree of the bag can be accessed due to the design of the instrument. Thus make sure that no cortical remnants are really left behind. Look at the alternate uses of the irrigating Y. Feeding the aspirating port, make sure that all the cortical matter is aspirated. The beauty is that this can also be used after the IOL is implanted in the bag. Retract the iris, see the free floating fibrils of the cortex, and then slowly aspirate it using the aspirating handle. Yet another use of the irrigating Y is to implant the IOL under irrigation. The leading haptic is guided under the CCC margin and the IOL unfolds slowly in the bag. The trailing haptic is then dialed into the bag with the aspirating port and the IOL perfectly sits in the bag. Another application for the irrigating Y is to be able to hold the IOL. Make sure that all the viscoelastic from behind the IOL is removed and the lens is gently placed back into the bag. Yet another use is to use the Y to hold on to the toric IOL to prevent rotation during bimanual IA, to remove the viscoelastic from the bag. Notice how the IOL does not rotate at all because of the pressure given from the irrigating Y. In such a scenario, the same irrigating Y can be used to lift the IOL and remove the viscoelastic if present behind the IOL. Once that is done, the IOL is safely placed back into the bag and the IOL is oriented in the right axis. In conclusion, the irrigating Y is a very useful instrument for an atraumatic retraction of the iris and aspiration of the cortical matter by avoiding the use of iris hooks in a non-dilating pupil or an intra-op meiosis. Alternative uses are feeding the aspirating port, residual cortical aspiration after IOL implantation, facilitates hydroimplantation of IOL to guide the leading haptic into the bag, help to lift the IOL, support it and clear the viscoelastic from behind the IOL, maintaining toric alignment by pressure on the IOL during viscoelastic removal.
Excellent. Thank you.
Very good. Has it been sent for patenting or something?
So there are some rules for patent, unfortunately, not this, but maybe
Okay, so I have one concern.
Yeah.
This Y dialer which is there in the front of the irrigation cannula,
Yes, sir.
the irrigation fluid is coming out from the top. The holes are made from the top and the bottom.
Yes.
This irrigation fluid which is coming from the top, will it not hurt the endothelium? If some sort of a, or would it be better if this was like this and still the holes would be on the both the sides?
So keeping it above and below, that actually maintains the chamber better is what we saw. We had one which had on the sides, but when we would turn the Y around, it would restrict our movements. In fact, there were around 2-3 more where the angulations were tried, but getting into the AC and out of the AC, it required viscoelastic injection and required the orientation to be changed. So finally we came to this where it was oriented
Because
above
this
and below.
fluid is going straight to the endothelium.
Yeah.
So maybe some specular microscopy can be done and seen what is
That's
happening.
interesting. I would do that.
So use it routinely or only when needed?
Small pupils.
Only small.
Small pupils, if there is any iatrogenic touching of the iris and the pupil becomes small, then
Not as a
otherwise-
routine.
Not routinely. This is for small pupils, rigid pupils,
So
and
available,
especially with femto.
available with? No, it can be used with any small pupil. And why especially with
Any
femto?
small pupil, and it's available with
So
epsilon.
there are many times when there is an intraoperative a small pupil, they
Yeah.
have started more or less 90% of the surgery is over.
Yeah.
Actually, it is the cortex tumor is the toughest part of the
Yes.
small pupil.
Yes.
Good. So who is the supplier now? Is available? Epsilon.
So maybe we can use a high molecular viscoelastic when we are using this particular instrument to coat the endothelium?
No, I think because the chamber, the fluid is already there, so jet of the fluid will not reach up to the endothelium with the force, because it's not the empty space. When you see outside, jet is coming out, but now the fluid is coming into the fluid chamber itself. It is not coming with the force. And with the sideways, it may irritate the iris which you are trying to push away. So it's perfectly all right maintaining the chamber and used for very small time, and the peripheral part I don't think it will cause any damage to the endothelium.
Moreover, in hard cataracts, we've seen if we are patient, we may have a CDO up to 35, but we are patient, we get a pristine cornea the next day. So I don't think it's the volume of fluid that turns over, it's the mechanical damage that is more important.
Correct.
And your mechanical damage is not happening.
Thank you very